Good afternoon, everyone. I see that we have folks still joining us. We will start promptly at 3 p.m. Looking forward to today's conversation.
Hi, this is Eliana.
Hi, Eliana. This is Kristen. We're going to get started at 3 p.m. promptly.
Okay, awesome. Is there anything that you need from me in the meantime?
No, it looks like we have about 27 attendees with us, and we have myself and three others from Child Trends on the line, and we're actually broadcasting now. So your invitation, as well as all of us at Child Trends, all of our lines can be heard by the attendees.
Okay, great. Thank you.
Looking forward to getting started. And for those of you joining us, we will get started in just one moment. All right, it is 3 o'clock, so we will go ahead and jump in. Good day, everyone. Many thanks to all of you for joining today's webinar. My name is Kristen Harper, and I'm Director for Policy Development here at Child Trends. I'm pleased to welcome you all to this discussion on creating healthy schools through state policy. So before we get started, I do want to cover a few housekeeping items. First, if you have any audio problems, we strongly recommend that you dial in rather than rely on the computer audio system. If you have other challenges during the webinar, please do reach out to my colleague here at Child Trends, Emily Fulks. You can use the chat function, or if necessary, use her email address to reach out to her directly. One thing to note is this webinar is meant to be interactive. We will periodically be stopping to answer questions. During the presentation, we are going to be keeping the lines muted. So if you have any questions, please send them using the chat box, and we'll stop to answer those questions at different points throughout the webinar. A last point I do want to make is that you will see links featured at different points during today's presentation. My colleague Emily will be sharing the links, copy-pasting them into the chat feature as we go along. So if there is a particular piece that we're presenting on that you'd like to follow up on right then and there, you'll be able to do so, because we'll be making the link more easily available to you. So there are three components to today's conversation. First, I'll be walking through Child Trend's landscape analysis of state school health policy. Then my colleague Renee Rieberg will showcase a new data tool that we've developed for state officials like you that illustrates the link between adolescent life expectancy and education opportunity. And our hope is that this tool will help make the case for stronger collaboration between education and health officials. And last, in our conversations with other state officials, we know that many of you have been interested in Child Trend's LEAP project, the Leadership Exchange for Adolescent Health Promotion. This is a 5-year effort funded by the Centers for Disease and Disease Prevention and Control. It's a 5-year effort to provide technical assistance to teams of education and health officials so that they can strengthen state policy in areas related to adolescent health. So just to get us started and give a quick foundation for why Child Trends is so focused on healthy schools policy and why we're trying to provide so much support, I do want to just provide a quick reminder about our current state policy context. We just know that you and other state officials today are just inundated with news about opportunities and challenges inherent in creating healthy school environments. And, it's everything from, how to address school lunch debt and school lunch shaming to how do we support students' social and behavioral and emotional needs. How can we position schools to be a partner in addressing trauma and adverse childhood experiences? What are ways we can better leverage Medicaid for schools? How do we address active shooters in school environments? It's just on and on and on in ways that is just different from years past. In the midst of all of this, we've been looking for ways to be a support to state officials like you working to create healthy schools. So I do also want to be really clear about what I mean when I say school health or healthy schools. We've used the whole school, whole community, whole child framework as our guide. It keeps our focus on the wide range of issues that influence school health. It includes 10 different domains at the intersection of education and health, from community involvement to social emotional climate to employee wellness to health education. And again, there's 10 different domains in all. And oftentimes, school health can feel heavily siloed. Sometimes, efforts to address violence prevention, for example, might not consider the implications for school discipline, or as we're thinking about school health services, are we considering the implications for family engagement or the opportunities to improve health services through family engagement? As we're trying to position schools as a partner in addressing trauma, is there room for conversation about how to address employee wellness and secondary trauma? So this framework also reminds us of the need to help state officials in the field at large think about the interconnections between these different components. So this is the foundation that we use for all of our work on school health. So to showcase one of our major pieces of work, Child Trends completed a 50-state analysis of school health regulations and statutes. Our purpose for doing this was to figure out the extent to which states were addressing the components of the whole school, whole community, whole child model in state policy, where we wanted to examine, for instance, where are there heavy areas of policy activity, what areas, what domains seem to be overlooked. And as we did this again, we also wanted to look at those intersections. And we have limited time today, so I'm not going to go through all of our findings, but I've pulled out those pieces that I thought might be of greatest interest to this group today. So for each domain, again, domains are health services, family engagement, community engagement, et cetera. We measured the percentage of related topics under that domain addressed within a state's policy. So for health services, for example, related topics might be health screening, school-based health services, services, vaccinations. So we looked at the percentages of those topics addressed within a state's policies, and we then assigned the state's domain to one of 4 categories based off the percentage of topics covered. If none of the topics were addressed, we gave that state a none for that domain. We considered the state to be low in that domain if a third of the topics were addressed. Moderate if they addressed 2/3, high if they addressed more than 2/3. And this assessment doesn't speak to the prescriptiveness of state laws, laws that include mandates or merely encourage a focus on a domain's topic areas counted equally towards the measure of a domain's comprehensiveness. After we rated each domain for each state, we then assigned an overall rating to states, which is the graphic you see here. States were rated on their coverage of all 10 domains. States with a deep coverage of the whole school, whole community, whole child model in its entirety received a rating of deep coverage. And that means that they have 6 or more domains that they covered comprehensively. On the opposite side of our rating scale were states with weak coverage, which had more than 6 low domains. So just to explain for a moment what that means in this graphic, if you look at Minnesota, Illinois, Colorado, Texas, Florida, and other states with a diamond in that darkest shade, we considered those to be the states that had the deepest coverage of the whole school, whole community, whole child model. They covered at least 6 domains comprehensively. And then on the opposite end of the spectrum were, North Dakota and South Dakota, which each had more than 6 domains that were covered, that had very low coverage. So just to give you a sense of how our rating scale worked. So this is how we used our analysis to give sort of an overview of the coverage of the whole school, whole community, whole child model. But we also did the same rating for each domain individually across the country. So, for example, we looked at health services. And again, there are a number of topics that we looked at for health services. And it looks like, over half of states, really did cover topics related to health services pretty comprehensively. And then here we see North Dakota, again, sort of on the opposite side of that spectrum with relatively low coverage in the area of health services. And just to look at this just with a little bit more granularity, there's a bit of difference if you look at the health services topic by topic. So really strong coverage of school-based health services in state policy, really strong coverage of allergy plans in state policy. And on the other side, not as much coverage of things like dental screenings in state policies. Only 24 states out of all examined actually addressed dental screenings in state policy. And just to look at another domain, we also looked at counseling, psychological, and social services here. We have, South Dakota, Ohio, and Arizona sort of appearing on the low end of coverage. But in this domain, again, there's, pretty strong coverage of, counseling, psychological, and social services in state policy for, roughly, half of the states. And to give you a sense of what topics we looked at for this domain, one of the things that was really striking for us was the extent to which trauma-informed practices really wasn't addressed in state policy. And as a reminder, the policies we looked at for this analysis were current as of the 2017-2018 school year. And at that time, only 11 states really had statutes or regulations on the books addressing trauma-informed practices. And then at the other end, school counseling certification was really addressed really strongly in state policy. And with other areas such as suicide prevention, around the middle, about half of states addressing that one. So again, for each of the 10 domains, we have analyses just like this, and within each domain there are multiple topics where we looked at, to what extent are states covering these issues. So all of the state data that we gathered is available in a database that is housed on our partner's website, the National Association of State Boards of Education. There's an interactive data visualization as shown here, as well as a searchable database to help you research how states have addressed different school health topics within statutes and regulations. We've also published summaries of our 50 state analyses in the form of state-by-state profiles and issue-by-issue briefs. This is another area where we have, a link down here. Definitely want to make sure that this is a resource that's available to you all. There's a lot to dig into, but hopefully we've organized it in a way to help you find pretty easily and quickly the specific information that you might be interested in researching for your state or for a particular issue or topic. So with that, I'll stop and see if we have any questions. And actually, I'm going to do something really quick and stop sharing for a moment. It looks like I keep getting very annoying pop-ups in my screen, and I'm going to see if I can't stop those from happening. But in the meantime, Emily, do we have any questions from the group?
We don't have any yet, but I would encourage people to use the chat box in your GoToWebinar browser that should be on the side of your screen and enter any questions when you have them.
Okay, so we're going to keep moving on. And Emily, I'm going to turn to you quickly for a check to make sure that this is presenting properly. You see the question slide?
Not yet.
Still? Okay. How about now?
All set.
Awesome. Thank you for bearing with me. I just want to make sure that we don't have any more pop-ups on my screen as we're going along. And my apologies if it keeps occurring. So with that, I'm actually going to turn things over to my colleague, Renee Rieberg, to talk through her work developing our data visualization on adolescent life expectancy and educational opportunity.
Great, thank you, Kristen. So switching gears to something a little more granular, so going from state policies to a more localized level, I'll be presenting a data visualization project where we examine the link between life expectancy and educational opportunity across the country. The project's entitled Mapping the Link Between Life Expectancy and Educational Opportunity. And spoiler alert, we found that teens in neighborhoods with high levels of educational opportunity have longer life expectancies. There we go. So we were motivated to do this project based on neighborhood level gaps in health and education. So in an average neighborhood across the country, a 15-year-old can expect to live to age 79. But in the 1% of neighborhoods with the lowest life expectancies, that 15-year-old can only expect to live to age 70. That's a 9-year of life difference. There's lots of different factors that go into that disparity, as I'm sure you know. But one that has been extensively studied is educational attainment. It's been well established that people with more education tend to live longer, but there's not a lot we can do with that information. It's really hard to mandate additional years of schooling, for example. So we took a step backwards. Took a step backwards and are interested in the link between educational opportunity and life expectancy. The thought process being that educational opportunity opens doors for educational attainment, which leads to longer life expectancy. And educational opportunity can be improved through policy interventions. So our research question is, what is the relationship between adolescent life expectancy and educational opportunity? In other words, how is the opportunity that a young person is given related to how long they live? We also came into this project with a policy objective. We were looking for a way to help education officials communicate the importance of educational opportunity and recruit allies in the health world. Just knowing about educational attainment doesn't do that because it's not actionable. that educational opportunity is. So I know that we're talking to health folks today, though, so the objective is a little different. Today we'll give you a couple ideas of how to engage with those education folks to support and lift up each other's work. So we started by, whoops, went too far. There we, oh no. Okay, so we started by defining educational opportunity. We were inspired by a recent report by the National Academies of Science about educational equity, and based on that report, as well as kind of broad literature on educational opportunity, we constructed a measure of educational opportunity with 4 domains, and those 4 domains are the quadrants on this figure. So they're effective teaching, access to rigorous academics, supportive conditions for learning, and non-academic supports. Within each of those domains, we have indicators of what that might look like on the ground. So within rigorous academics, that could be illustrated by offering AP courses, offering dual enrollment, which is where students receive college credits in high school, the number of advanced math classes offered at a high school. Within supportive conditions for learning, we really focused on a lack of reliance on exclusionary discipline and low levels of chronic absenteeism. For non-academic supports, we are looking at access to those key support staff, school counselors, school nurses, psychologists, and social workers. And then within effective teaching, we're looking at access to experienced teachers. The gray bubbles on this chart show the level of access for a high school in an average neighborhood. So the average neighborhood does have access to AP courses and dual enrollment courses. There's about 1 advanced math class per 100 students, and about 90% of teachers have 2 or more years of experience. So once we came up with this measure, we assigned the value of educational opportunity to each neighborhood in the country. A higher value of educational opportunity is better, indicates more access to opportunity. And we did validate this measure to make sure that it predicts graduation rates as you would expect, and indeed it does. All right, I'm going to that's 1 slide now. Great. Now. All right, so here's what we found. In the scatter plot, each dot represents a group of neighborhoods. On the x-axis along the bottom, we have educational opportunity and then life expectancy going up the y-axis. The orange line is the trend line between the two. You can see that there's an upward slope here, indicating that neighborhoods with higher levels of educational opportunity also tend to have longer life expectancies for adolescents. To quantify that, make it a little more concrete, teens in the 20% of neighborhoods with the highest level of educational opportunity, that's that white box on the right, can expect to live 0.7 years or about 9 months longer than their peers in the 20% of neighborhoods with the lowest level of life expectancy, which is the box on the left. So we took that information and then also organized it into an interactive map with schools and neighborhoods. So here's an example from Baltimore. The dots are schools, and then the shaded regions are different neighborhoods. For the schools, orange dots represent schools with low levels of educational opportunity, and blue with higher levels of educational opportunity. For the neighborhoods, those that have darker shading have longer life expectancies. So you can see here that in Baltimore, there's a pretty clear relationship. The blue schools with more educational opportunity tend to be located in the darkly shaded regions with longer life expectancy. It's important to recognize, though, that this is not entirely an education story. There's a lot more going on here. So where possible, we've provided some blurs with historical context around why these patterns exist, highlighting kind of localized patterns of segregation, deindustrialization, really historical patterns that have set us up for the scenes you see here. So Baltimore is one example, but the map we've created is interactive and available for the entire country. You can navigate it by dragging the map around, or you can jump to a city in your particular state using this Jump to City box in the top right corner. We've chosen a couple of cities for each state to make it easy for you to navigate to your area in the map. There are also data available for rural areas, which you can access by kind of panning across your state or just moving out from urban areas. I want to highlight Maine and Wisconsin here because I know we have folks on the line from those cities. We do not have life expectancy data for those states, but the school data is there. So once you've found your area, you can zoom in and get information on particular schools and neighborhoods. So this is an example in Catonsville, which is a suburb of Baltimore. If you click on a school, more information will be pulled up about it. So here we have Catonsville High School, which is part of the Baltimore County Public Schools School District. We've also provided information on how the school scores in each of those 4 domains of educational opportunity, as well as an overall score. So this school scores a 4 out of 5, so pretty good. It looks like they are strongest in access to rigorous academics. So we encourage you to go to the website, we'll provide the link, and explore your own area. After you've had some time to play around with the tool, we have one potential idea of many possibilities of how to use this tool to go deeper and affect change. So the first step is to find your peers on the education side and form a team of education and health officials to work together. The folks you want to connect with might include state departments of education, particularly their student supports teams, state boards of education members, and your state's children's cabinet. Once you have assembled your team, you can review our definition of educational opportunity laid out in that circular measure. And then you can use the map to find neighborhoods where there's both low life expectancy and low educational opportunity. That's those areas with the white shading and the orange schools. So in Baltimore, you might want to figure out what's going on in this region. You can review educational opportunities in the high schools in those neighborhoods, and then move forward to implement strategies to address educational opportunity gaps. Now, I recognize that's incredibly vague, implement strategies to address educational opportunity gaps. There's many ways to go about that. One potential way would be to look at other health outcomes in that area, bring in a data person and try to see what other patterns are going on here. And since everyone on this call today is a state health official, we thought it would be helpful to provide one concrete suggestion as to how you might engage education officials and where there might be some natural areas of collaboration. So under the federal Every Student Succeeds Act, or ESSA, your partners in state education agencies are required to identify 2 types of schools: targeted support and improvement schools and comprehensive support and improvement schools. Those schools with academically struggling subgroups of students, which might be English language learners, different racial and ethnic groups, or students with disabilities, are targeted support and improvement schools. Schools that are generally low performing and have low graduation rates, for example, are comprehensive support and improvement schools. Under ESSA, states are continually looking for ways to strengthen the performance of both of these types of schools. So our map highlights schools with low educational opportunity and communities with low life expectancy. And wherever there's overlap between these schools and schools that the state has already identified as areas to focus on, those may be natural areas for collaboration. Okay. Now I'm happy to answer any questions about this part of the presentation.
We have a question here that says, can health officials use this tool to create partnerships with education partners for innovative programming for youth? And a second part of that question asks, can these align with the purposes of their agency/division?
So this is Kristen Harper. So we provided one idea as to where you might create partnerships with education officials, really focusing on the Every Student Succeeds Act. So one thing that I think this tool really lets you do is sort of identify, work with your education partners to identify, a specific neighborhood or group of neighborhoods or a specific group of schools. This tool only includes high schools that could be the focus of a specific program. One thing that probably would be most helpful and probably of greatest interest to your education officials is any school that's on their list of targeted support and improvement or on their list of comprehensive support and improvement schools. Now, regardless of what schools or what communities you identify as your target, this tool can also help you figure out what type of programming might we want to provide. And as Renee said earlier, one of the beautiful things about the tool is that it, instead of just looking at education attainment, it looks at education opportunity. And that definition of education opportunity, along with the map, sort of tells you how, where, what is the rationale behind, any one school's challenges with education opportunity. Is it they really just don't have supportive conditions for learning? Is, the academic, piece just not there, or is it, something else is going on? We hope we've provided a data tool that gives you at least some indication of what conditions might be happening in those schools, particularly for the group on the phone today, conditions that might be related to, issues of greatest importance to you, like, access to school nurses or access to school counselors, to school psychologists. What's happening with chronic absenteeism? What is happening with school discipline? And might there be challenges addressing, the needs of children with externalizing behaviors? Those, that information can guide you in thinking through with your education partners, what does the programming, what is the service, what needs to be the strategy we come up with in order to address the needs of those schools. So it's both the tool serves both a targeting function, but also a strategic function where you can actually think of what is the programming that might be most useful. Emily, are there any other questions at this point?
Not right now, but we will check back in if more come in as we go.
All right. So at this point, I'm going to introduce Kayla Garcia, who I know many of you have been interested in learning about our LEAP project, and Kayla is working hard as a part of that team. So Kayla, walk us through LEAP.
Great, thanks so much, Kristen, and thanks, Renee, for your presentations thus far. I'm really excited to talk with you all about LEAP and this project that's being funded by CDC and that we're working on with the National Coalition of SCD Directors and in partnership with NASB, just to kind of bring states together. Just a disclaimer, so while this work is funded by CDC, the opinions, findings, and conclusions don't necessarily represent the views or official position of HHS or CDC. But we'll go ahead and get started. So, the overarching goal of the LEAD project is to improve policy and practice in support of adolescent health, and we're paying special attention to the area of sexual health. So this project works toward that goal through capacity and knowledge building, network development, and collaboration. Through our efforts, we're hoping to move states toward an evidence-informed approach toward policy and practice. As mentioned, this project does focus on adolescent sexual health, and it does this by centering around these 3 core domains of sexual health education, sexual health services, and safe supportive environments. So these domains align with CDC's 1807 grant program that works with districts to support adolescent sexual health. And within each of these domains, the LEAP project team has articulated 3 potential pathways that state teams can take toward improving policy and practice. Those pathways are building staff capacity, community and parent engagement, and increasing student access, and ensuring the quality of programs and services. And so the next few slides show some examples of each. So here on our first slide, we have the domain of sexual health education. Here under building capacity, that for staff, that might include teacher training and teacher certification to teach different types of sexual health education curricula. For parent and community engagement, that could include finding ways to share with parents about different curricula, helping get them on board and bringing buy-in, just getting them involved in general. And then for increasing student access, that can include making sure that the curriculum that's selected meets specific standards, is comprehensive in its approach, covers content like how to support LGBT students. Another strategy might also be looking at graduation requirements so that students are required to take a health education class to graduate. So those are some options here. Under sexual health services, for staffing, we might look at hiring or setting a max caseload for different school health staff, just to kind of prevent burnout and make sure that they can meet students' needs effectively. With community and parent engagement, we might think about things like minor consent and how students are able to access services if their parent might not be fully supportive. We also can look at things like interagency and community partnerships to help support a school in providing services, again, to limit the burden on school staff. And finally, for increasing student access, we might look at things like school-based health centers or other similar school-based service provider models and referrals and things like confidentiality. And in the third domain of safe and supportive environments, again, we see this idea of professional development for staff as being a key opportunity for building staff capacity. We also see, again, this idea of community and agency partnerships and ways to engage parents in schools in just general safe supportive environments. And then for increasing student access, we might look at things like student-led clubs like gay straight alliances, or I think they're also being moved towards being called gender sexuality alliances, just general, and also incorporating school connectedness and positive youth development frameworks within schools as a way of operating. So these are a lot of different strategies. These are just some examples of the approaches that state teams can and are focusing on through LEAP. And so what does this actually look like for participants? Throughout the project, and particularly in the first 2 years after joining, the LEAP project team will provide technical assistance to state teams. This TA is going to largely be virtual, but it does include opportunities for in-person site visits, meeting facilitation support, and/or conference scholarships. On this slide, the blue column represents everything that state teams will be involved in, the kinds of activities that they'll have to do. The green and orange columns represent the support that we, the LEAP team, are providing to state teams throughout the process. And so as you can see, we're doing a lot to kind of support state teams, and we're hoping that whatever we're asking of them is not too much. And so we're going to look at each of these phases a bit more closely. So LEAP really begins with the development of a core team. And this core team consists of 5 individuals. At minimum, we hope that the state team consists of a representative from the state health department and the state education agency and/or the state board of education. So we really do want it to be a partnership between the health and the education teams. So I think that question might have been asked just in the presentation before. So that's a core component of the LEAP program. Individuals from these agencies will ideally represent key decision makers who have the capacity to drive work forward and make decisions, and they also have a vested interest in adolescent sexual health. And the remaining two or three team members can be pulled from a variety of stakeholders. Previous teams have included other state agencies, statewide coalition or nonprofit leaders, advocacy partners, school districts, school health personnel, and others. So the door is wide open in terms of who each state feels is the best candidate to kind of fit in the core team. And I'll also say that while this core team is the group that's being convened at DC, the teams aren't limited to just this group of 5. This is to kind of get them started, and then hopefully as the project goes along, they can draw in more folks. So once the state team has committed to the LEAP project, they'll receive a state profile. And within this profile, they get a snapshot of the policy and data landscape within their state. And the idea is that providing some of this information will help spark some initial conversations about gaps, priorities, and opportunities. They also are asked to do a readiness assessment, which is a brief questionnaire, just to kind of help us identify what are the best ways to support teams in the process. It also can help us identify strengths and where their experiences might be good fits to share with the other state teams, both in their current cohort, future cohorts, and even states from previous cohorts. And so both the state profiles and the readiness assessment are completed before this in-person training in DC. And so once the core team is assembled, they come to DC for an expenses-paid in-person training. The training lasts approximately 2 days with sessions that allow states to meet some of the goals shared on this slide. In particular, state teams use data. They work together with their individual teams as well as other state teams that are in their cohorts. And they really listen to the perspectives from various stakeholders. And the goal for all of these sessions is so that they can start putting together an action plan for how they would like to improve policy and practice in support of adolescent sexual health. So we actually just finished our second cohort of trainees. We had revamped our first training, and we're pretty excited with how it went. I think we generally got a good level of engagement, and people really valued the time to be able to connect with others in their state who they haven't worked with before, and to hear the perspectives of other states who were in similar boats with them. And so here are some examples of what other states have kind of committed to, or the kinds of activities that they've listed in their action plans as part of this training, and things that they want to accomplish through LEAP. So there's a lot on this slide. I think this does a great job of representing all the different types of things that people got excited about and that they wanted to, so the buzz that they had for trying to work on adolescent sexual health in their state. Some of these may resonate with you and be things that you're like, oh yeah, this is something that I feel like our state would like to do. Or you may have other things in mind that you know would work a little better. But yeah, there's just a wide range in what states can focus on. And as you saw from that previous slide, there was a lot of activities, some of them very lofty ones, and lofty goals that the state team set. And so we know that state teams need support. And this slide represents that support and how it's delivered by us. So as I mentioned, most of the support will come virtually through email and phone or video conference. We also have quarterly webinars on topics relevant to adolescent sexual health, and also just engaging with different types of stakeholder groups. So in our last webinar for the LEAP team, we had a session on kind of what is the language used in the education, among education folks, and how do you kind of connect the things that we're talking about in LEAP to education priorities and the language that they use. All of this support is backed by subject matter expertise. So you have Child Trends, NCSD, and NASB serving as a kind of core, but we're also supported by a great advisory board. It includes folks or entities like the National Conference of State Legislators, GLSEN, the Council of Chief State School Officers, and ASPO. So there's a wide group of people who have a lot of different types of knowledge, and they're happy to kind of share that knowledge and help state teams reach their goals. And finally, we also want to honor the expertise that each of our states bring. So we also have a Slack and a share file so that even after the training, when states aren't in the same room, they're still able to talk with each other and share what's happening with them, how they're progressing, what lessons they're learning, what resources they have. I know in our latest training, Nevada kind of shared that they had a specific resource, and right away they're like, we're going to post it to Slack. And so in real time, I watched them add it in there, and it was a great thing to watch. And so this map represents all of our LEAP participants thus far. You can see we have folks spread throughout the country. We have a contingency here out west. We have a couple in the Midwest, a good amount structured in the Mid-Atlantic and Northeast regions. And I'm based in North Carolina, so I'm really excited that North Carolina was one of our first states and that they're representing themselves in all this. We do have a few states confirmed for cohort 3, which will happen in July. We're going to be reconnecting with them over the next few months to just kind of reconfirm their participation and make sure that nothing has changed in terms of their capacity to be part of LEAP. That being said, while this is showing the confirmed and official LEAP participants, we have reached out to a whole bunch more states. We've reached out to, I think, folks in North and South Dakota. I think some folks in like South Carolina, Tennessee, Kentucky, Iowa, Arizona. So and we're hoping that those states do eventually come to join us. And it was just at the time that we reached out to them, they weren't available to participate in LEAP. And so actually some of them may already be part of our cohort 3, but we're hoping to kind of continue reaching out to folks over time. And that brings me to my last slide, which is if you would like to be contacted to participate in LEAP, or if you know that based on this map, that we have a LEAP team in your state and want just to connect with them, please fill out this Google form and let us know. We want to make sure to foster collaboration and make sure that people can reach out to the work that's being done in their area. Additionally, if you have any questions beyond this presentation, please feel free to contact me at the email address below. And with that, are there any questions that you would like me to answer now?
We actually have 2 questions here, one about the LEAP training and one back to the data visualization, but I will start with you, Kaylor. This question says, for state teams participating in LEAP, what sector or agency typically serves as the project lead or backbone, or does it vary between states?
So I would say it varies between states, although as a LEAP team, we noticed this from our first cohort that when they started, some of the state teams didn't initially identify that, and so we made a conscious effort in our second cohort to really kind of have a way for the education and that state education and state health agencies to really have time to connect and kind of jointly form that backbone to be the project coordinators for the So ideally, we would say that we hope those two agencies are working together to pool resources, because we know it's a lot to ask any one state agency to do on their own.
Thanks, Kaylor. And Renee and Kristen, I'll direct this one to you regarding the data visualization. One of our attendees from Hawaii asks, was ESL, English as a Second Language, or the schools in areas with higher immigrant populations considered as a factor in the evaluation while creating this tool? And this attendee notes that their community in Hawaii is very diverse, and they often encounter many areas with students that have low literacy levels, with English being their second language.
You want to take first stab, Renee, and then I'll build?
Sure. So we really wanted to include something about the ratio of staff supporting English language learner students to English language learners, and similarly for students in special education and a couple of different other categories, but that data were just not available across the country.
Also, one of the features of the map tool that we didn't delve into, and absolutely hope that folks will take a look at it and play around with it, is the filtering feature. It doesn't change the data on the map, it just changes its presentation. There is not a filter that focuses on immigrant populations, but there are filters to show the percentage of communities of different, racial, ethnic groups, within a particular community. So if you apply a filter that, that says, for example, I only want to see communities that have, at least, 50% or at least, 75% Black population, for example. Those might not be the exact percentages, don't hold me to them, but for example, it would erase from the map all of the communities that don't reach that criteria. So the data is the same, but the filters help you to zero in on particular communities. And we have filters by race and ethnicity. I think we have filters by for different socioeconomic factors. Renee, do we have any others?
That covers it.
Covers it.
And we have one more here, more of a comment, but I'm wondering if any of you can speak to the context here. One of our attendees from Florida is mentioning that even if they are working collaboratively, on any of the various domains, some Florida school districts are in counties that are defined as fiscally constrained. So she notes that this limits funding for both education and public health, meaning limited staff and staff time to implement new initiatives and institutionalize any new policies. Can any of you speak to this in a broader context?
Yeah. So there's a number of school health projects, that we're working on. I am not intimately familiar with districts designated as fiscally constrained. I'm not familiar with the exact circumstances that go into that designation, or if it's a label that's generally just to apply to a district that just doesn't have much resources, or if it's a label applied to a certain policy limitations. But in either circumstance, one thought is that I would hope that collaboration between education and health might generate different policy opportunities that might alleviate different fiscal constraints. One, option, which not always the strongest or longest lasting option, is thinking about ways to collaborate for proposals for discretionary grant programs at the federal level, to alleviate, even if it's in a short term, many of those federal programs, especially from the U.S. Department of Education or the U.S. Department of Health and Human Services, they generally last anywhere from 3 to 5 years. And so, even if they don't last terribly long, they, can provide some initial funding that can help set a direction for community. So, safe and supportive schools grants from the U.S. Department of Education. I believe there should be grants coming up, or perhaps have already gone out in 2019, grants focused on trauma and adverse childhood experiences. They think in the recent federal appropriations, there's some suggestions that there might be some grants forthcoming related to social emotional learning. So all of those are different opportunities. But another big area of policy churn that we're seeing is around the use of Medicaid in schools. Back in 2014, the Centers for Medicaid and Medicare Services shifted their guidance such that schools can now seek Medicaid reimbursement for care that is provided to students for free. So, thinking about things like vision screening, dental screening, other types of services, or funding to support, especially that school nurse, position. At least in terms of federal policy, there's new flexibility to leverage Medicaid for services that are generally provided for free, so long as children are Medicaid eligible and enrolled. But however, even though the federal policy has changed, many states still vary pretty widely with respect to whether or not they allow schools to take advantage of those funds. So, that could be an area of potential collaboration, is figuring out, okay, we know which schools need help. We have initial thoughts about how to help them. Where do we get the resources from, and what can we put on the table? A rather extended answer, but just providing some initial thoughts as to where folks might be able to go.
Yeah, and just to add on to Kristen's response, in terms of the LEAD project, I think for us as a team, we're really trying to push states to kind of review what is already in place and recognize some of the priorities that have been set and activities and things that already exist, and how to best leverage them so that they're working in synergy together in service of adolescent sexual health, rather than having things feel like they're all in discrete buckets and not related at all.
Yeah. Another area of funding to keep your eye on, again, reminding myself that we're speaking mostly to state health officials on this call, is under the Every Student Succeeds Act. There is a formula grant program under Title IV of ESSA. It's called and Kayla, correct me if I say this wrong, the Student Support and Academic Enrichment Program, SSAE. It's still a relatively new grant program. I believe in 2017 it was funded at $400 million. $400 million distributed to states. Now, the Safe and Healthy Schools component of that bucket of funds is just one of three buckets. That it's not like that the entirety of that $400 million goes to safe and healthy schools topics. But in the aftermath of Parkland, that bucket increased from $400 million to about 1.2. I think now we're closer to $1.3 billion. So again, all of that money doesn't just go to school safety and student health. It's one of three topics in there, but we're now talking about a much, much larger pot. And perhaps, especially if you're able to come to the table with some ideas about how you can, support states in thinking about how do you address schools that the states have already placed a high priority on. Perhaps, there's also opportunity for you to provide some thoughts about ways that they can use that pot of funding as well. Emily, are there any other questions that we've gotten?
It looks like that's all we've got for now.
Okay, awesome. So, the webinar just is sticky with the slides this afternoon. Not sure why. Okay, last slide. So definitely want to thank folks for listening. One other big thing we want to be sure to share with you is, apart from, we've tried to give you a sense of, where are we right now in terms of state policy, what might be tools to help you engage, folks on the education side, and then where is there actual technical assistance to help bring those teams together and begin work. In addition to all of that, we have launched a new effort that's going to run from January to June to provide any state official with regular updates on research and policy at this intersection of education and health. So we have a tailored e-newsletter that's going to go out weekly that has new information about any research that's coming on, any technical assistance opportunities that may be available, and it'll go out every Wednesday. If you send us an email at schoolhealthpolicy@childtrends.org, we'd be happy to sign you up to receive that e-newsletter. And then coming in February, any state official or policymaker that's in California, Kentucky, Nebraska, Tennessee, Wisconsin, Washington, or New York can also send an email, again, to schoolhealthpolicy@childtrends.org and seek assistance with different questions you may have about the research, best practices, what's going on in policy, and we're more than happy to provide you with that help. So again, that's running from January to June to pilot for us to think of new ways that we can again be of assistance to you. And with that, I also want to give a huge thanks to AmChip, who helped us pull together this presentation for today. Absolutely excited to have a chance to connect with you all, and that would not have been possible without AmChip. I know, Ileana, if you're still on the line, if you have any concluding thoughts, I'd leave those last words to you.
Sure, and I want to thank our colleagues at Child Trends for helping to put this together so quickly, and to all the attendees who, on a fairly quick notice, were able to make time to listen in on some of these great tools and resources. So the Association of Maternal and Child Health Programs works with state Title V directors under the Maternal and Child Health Block Grant, and adolescent health is one of the population domains that the Block Grant focuses on. So there's a lot of great work happening, and data and tools that we can utilize from Child Trends to help foster those partnerships for interventions and strategies so that we can improve health outcomes for young people. So I appreciate the partnership, and I look forward to connecting with our members through AmChip, as well as our partnership through Child Trends, to see how we can foster this collaboration further.
Thank you so much, Ileana. This was an incredible opportunity. Thank you so much for giving us the time, and to the rest of you for joining and listening in. We're just about at the top of the hour. Please do enjoy your afternoon and your evening, and look forward to hearing from you. Take care, all.